Welcome back, medical students, to another edition of The Explainer. Today, we're tackling an absolute classic, a high-yield topic that shows up on the wards and on your board exams time and time again, typhoid or enteric fever. We're going to break down this systemic infection using a really structured, logical approach. By the end of this session, you're going to have a crystal-clear mental map of exactly how this pathogen operates, how it presents week by week, and exactly how we manage it.
Okay, let's dive right into this. Here's our roadmap for today. First, we'll look at etiology and pathogenesis. Second, the 4 weeks of symptoms. Third, investigations and lab diagnosis. And finally, treatment and carrier management.
Starting off with Section 1, Etiology and Pathogenesis, or as I like to call it, the fecal-oral invasion.
To truly appreciate this disease, you've got to realize it is historically one of the biggest killers of the human race. So let's get our terminology absolutely straight right out of the gate. You're going to hear enteric fever and typhoid fever used interchangeably, but they are the exact same systemic infection. It's classically defined by a high-grade fever and major GI upset that lasts for exactly 1 month, literally 4 weeks. And that specific duration, that's a key differentiator. For example, it helps you easily distinguish it from something like rheumatic fever, which typically drags on for about 3 months.
So who's the actual culprit here? The infectious agent is primarily Salmonella typhi, causing about 75% of cases, with Salmonella Paratyphi making up the other 25%. What are we dealing with? A gram-negative enteric rod. Now, the only source for this is another infected human being, and it's transmitted strictly via the fecal-oral route. Once ingested, the incubation period is usually anywhere from 6 to 30 days, but you're typically going to see those symptoms pop up right around the 10 to 20-day mark. Though heads up, some rare cases can present as early as 3 days.
Now, what's really interesting about this slide is tracing the bacteria's physical journey once it gets inside the patient. After entering the gastrointestinal tract, Salmonella colonizes, multiplies, and directly invades the GI mucosa. From there, it basically takes 2 main systemic highways. First, it hits the blood, setting up shop in organs like the liver, the gallbladder, the heart, lungs, brain, and even bones and joints. This blood-borne spread, that's what drives the profound constitutional upset. Second, it invades the lymphatics, specifically zeroing in on the abdominal lymph nodes and the spleen. And it's this local lymphatic invasion that causes the severe GI upset.
Moving on to Section 2, 4 weeks of symptoms. We are now tracking the pathogen's evolution on a ticking clinical clock.
Now that the pathogen has a solid foothold in the blood and lymphatics, you really need to think of typhoid as a ticking clock. The whole clinical picture unfolds over a very consistent 4-week timeline. Week 1 is the week of invasion. Week 2 is advancement. Week 3 is the supercritical week of complication, and week 4 is recovery, or convalescence. Seriously, memorize this framework, because literally everything from your patient's symptoms to the diagnostic test you order is going to depend on exactly which week they're in.
All right, let's look closely at week 1, the week of invasion. Your patient will show up with prodromal stuff, headaches, general malaise, but the real high-yield buzzwords for your exams are the constitutional upsets. They'll have a high-grade fever over 101 degrees Fahrenheit in a classic step-ladder fashion, meaning it steadily climbs higher day by day. Check their mouth on the physical exam. You'll likely see a white-coated tongue, which is actually just a nonspecific sign of vomiting, thanks to stomach acid acting on the tongue. Plus, expect GI upsets, abdominal pain, nausea, and notably, diarrhea in kids, while adults will much more commonly complain of constipation.
Also during week 1, you absolutely must check the pulse. Why? Because you are hunting for phagot sign, also known as relative bradycardia. Normally, as a patient's core temp goes up, their heart rate paces up right along with it, usually about 10 extra beats per minute for every 1 degree rise. But in typhoid, the heart just can't keep up. You might see a blazing fever of 103 degrees, but a pulse of only 92. And the pathophysiology behind this? It points directly to subclinical myocarditis caused by the systemic infection.
So we move into week 2, advancement. That high fever and GI upset, they don't just persist, they get worse. Plus, we get some new physical exam findings. Since the bacteria have been busy multiplying in the lymphatics, you'll now be able to palpate splenomegaly. And in about 40% of patients, you're going to see rose spots. These are little red eruptions that pop up mostly on the trunk, specifically around the chest and abdomen.
So the crucial point is week 3, the week of complication. If your patient has a milder case or just hasn't gotten the proper antibiotic course, this is exactly when local and systemic disasters strike.
Locally, in the gut, that mucosal invasion can lead to massive GI hemorrhage, or even worse, GI perforation leading to full-blown peritonitis. Systemically, all that pathogen in the blood can trigger hepatitis, acute cholecystitis, clinical myocarditis, pneumonia, meningitis, septic shock, and even DIC, disseminated intravascular coagulation. This week is exactly why typhoid has such a deadly historical reputation.
Finally, if the patient makes it through week 3, we hit week 4, the week of recovery. Fever, GI issues, pulse, ECG, they all finally start to normalize. But hold on, the story isn't completely over. There are 2 tricky fates left. First, they might get relapsing typhoid, where, after about 10 days of looking totally fine, the typhoid comes roaring back. Or, second, they might transition into carrier typhoid, which, as we'll see, is a massive headache for public health.
Which brings us right into Section 3, Investigations and Lab Diagnosis.
And this brilliantly illustrates how you absolutely must time your labs perfectly to our ticking clock. If you order the wrong test at the wrong time, you'll get a false negative and delay life-saving treatment. Look at how logical this is, based purely on where the bacteria are heavily concentrated. Week 1, you order a blood culture. Week 2, as the immune system wakes up, you check for antibodies with the Widal test. By week 3, as the pathogen is shedding heavily from the biliary tract into the gut, you go for a stool culture. And finally, in week 4, you order a urine culture.
Now, analyzing the specific sensitivities here, blood culture is far and away the investigation of choice. If you do it at less than 10 days of illness, the sensitivity is over 90%. So what about serology, like the Widal or Typhi tests? Well, Typhi has a decent 70% sensitivity for detecting IgM and IgG, but that older Widal test, it's only got about a 40% sensitivity and comes with a super risky 15% false positive rate. So for sure, early blood culture remains your gold standard.
Beyond just the cultures, you're definitely going to order some supportive labs. A complete blood count will classically show pancytopenia. That's a drop in red cells, white cells, and platelets across the board. Because the liver takes a big hit, your liver function tests are going to show deranged AST and ALT enzymes. And if you grab an abdominal ultrasound, it's going to visually confirm that splenomegaly and reveal mesenteric lymphadenopathy, basically proving that lymphatic invasion we talked about earlier.
All right, on to our final stretch. Section 4, Treatment and Carrier Management.
Okay, we've got our diagnosis. Now how do we actually eliminate this thing and stop it from spreading? Our medical management cascade happens in steps. Step 1 is supportive. Antipyretics for the fever, antiemetics for the vomiting, and IV fluids to keep them hydrated. Step 2 is your specific antimicrobial therapy. Your standard go-to regimens are either injection ceftriaxone 3 grams IV daily for 14 days or ciprofloxacin 750 milligrams twice daily, also for 14 days. Now, if you're dealing with relapsing or resistant typhoid, the drug of choice pivots to azithromycin, 500 milligrams twice daily IV, but just for a 7-day course.
But what if your patient becomes a carrier? Let's be clear on the definition here. A carrier is someone who harbors the pathogen but is completely asymptomatic. No signs, no symptoms whatsoever. But, and this is a huge but, because they are still shedding the bacteria, they can unwittingly transmit the disease right back to others through that fecal-oral route we established at the very beginning.
Let's move to the next slide and see how this alters our protocol. If someone is identified as a carrier, they need a massive, extended course of antibiotics. Ciprofloxacin 500 milligrams twice daily for a full 6 weeks. And if that fails, the ultimate treatment of choice is actually a cholecystectomy, surgically removing the gallbladder. Crazy, right? But why? Because the gallbladder is the exact physiological hiding spot where Salmonella camps out in a carrier.
So when can we finally definitively declare a patient cured, whether they had an acute infection or were a carrier? The criteria are actually incredibly strict. A patient is only considered fully treated and cured when they give you 6 consecutive negative stool or urine cultures. Only then can you be 100% sure they aren't shedding and aren't a risk to themselves or the community.
Which brings us to a final thought. We've mapped out the clinical presentation, we've memorized the 14-day and 6-week antibiotic regimens, and we've even talked about surgically removing gallbladders. But let's zoom out for a second. If typhoid is exclusively spread via the fecal-oral route from infected humans, what kind of massive structural global changes in sanitation, clean water access, and public health are truly required to finally eradicate what is historically the biggest killer of the human race?
It's a question that goes way beyond the hospital ward. Keep that in mind as you study. Thanks for joining me on this explainer, and I'll catch you in the next one.